Thank you again. I'm very happy now because this is the session dedicated to insular surgery, and I would like to thank again the organizer, and especially Santiago, for asking me to share my experience regarding the diffuse low-grade glioma involving the insula, but specifically to try to focus a little bit the talk now on technical issues, speaking about the transopercular approach. I will not too much insist on the fact that these tumors are very frequently located within so-called eloquent areas in approximately 1/3 of cases within this paralimbic system. I mean the insula plus minus the orbitofrontal, frontopercular, and or temporopolar and or temporomedial structures. But it's very exciting because now we are doing more and more work in order to make the link with the previous session, I mean the neurocognitive assessment, in order maybe to better understand why, not why a tumor is occurring, but why specific locations in the brain, because for instance, in our series, and I think it's more or less the same in UCSF, less than 5 to 7% of low-grade glioma are located within the occipital lobe. And we had this first observation 15 years ago, but to be honest, today it's still complex to understand that. So the link between the evolution of the tumor and the location. I will not insist too much about the fact that, of course, this insula is not very well known because for a long time not studied except some anatomical study, and that's it. And now, once again, we start to understand this connectivity between this raised island and the rest of the brain. And it's very exciting to start to do again dissection, but with these functional and oncological issues, and not just to see the classical short or long gyri, but also to better understand the connectivity underlying underneath this insula. And you will see that, of course, we will make the link with the intraoperative mapping at the level of the temporal stem, especially, and synapse fascicle and the inferior fronto-occipital fascicle. In other words, when you have the habit to do a dissection into the lab, I said to many young students, don't see the brain itself, but try to imagine the function. The discussion we had with Santiago this morning. And speaking about function, we are not reasonable because for approximately 1 century, we said the insula we don't care in the classical book of neurology. And suddenly, with the development of functional imaging, for approximately 10 to 15 years, the insula was involved in everything, including emotion, language, cognition, consciousness, and so on. So I think we should probably find a good balance in between and to consider this plurimodal area as a hub within a wide network, once again, and not just yes, no, black, white, useful, not useful. So now we have understood that there is this island with very frequently low-grade glioma, a connectivity around, the capacity to compensate, but not with total illimitation of neuroplasticity. And the question will be, again, how to remove as much as we can of the tumor as earlier as we can, according to the discussion we had this morning, according to functional boundaries of the patient. And once again, now the same slide as this morning, but after the session you had, and for everyone, it's an evidence that when you start to have this kind of tumor in this location especially, you have already some cognitive disorders and especially attentional processing disorders. This morning, you saw that 30% in the meta-analysis you did, thank you, Pierre-Rob, and your team, 30% of attentional deficit, 5% of language deficit. Of course, subtle, sophisticated functions, but be objective. And definitely, it's related also to a disconnection syndrome. So in the work I heard this morning, in fact, you started to identify some correlation between the location, lobar location, and the deficit. And I continue to believe on the fact that you miss something, namely this connectivity, in order to better understand why this patient had probably a deficit regarding the frontoparietal loop. Is just one example. So now, the link with what you did yesterday, so oncology, structure, function, functional imaging, intraoperative mapping, and finally, quality of life. Everything is linked. And in the classical book of neurosurgery, when we speak about the insula, the goal is just to split the sylvian fissure and to remove the ball within this area, and that's it. No, we should see the connectivity underlying this area. So awake mapping, I will not insist about that, but you will see even in the right non-dominant hemisphere, and you will tell me why to wake the patient in the right insula, because what you can imagine now, emotional process, multimodal semantic processing, integration between different functions, working memory, attentional processing, and so on and so on. Now, I have not to insist, so I will speak about, in this setting, transopercular approach, and why not to open the sylvian fissure. First, why? So I will reference the Bennett citation we spoke about yesterday. I mean, because they did the job in UCSF and in cadavers. They demonstrated that if you remove the operculum, you have a better surgical exposure. And as you know, it's very important, of course, if you want also to remove more tumor, but to identify the pathways in the dead, because sometimes we can have a problem of visualization of this area. So it's not our work. Everyone agrees with the fact that if you save time to just split the sylvian fissure or to remove the opercule, in the second case, of course, you will see better. So it's better for surgery. Second, because you will see movies at the end. Some of you know already these movies, but I have the habit to do subparial dissection. No coagulation, never within the brain except the cortical surface after intraoperative cortical mapping, and that's it. And if you do subparial dissection, you will never, I touch wood, but any problem, speaking about the sylvian arteries and its branches, especially no spasm. And to be honest, some colleagues from the MD Anderson came to Montpellier also. They have seen, of course, insular surgery, and they told me, as you know, we have the habit to split the sylvian fissure. But offline, they told me it's really a nightmare because, first of all, it takes time. Second, sometimes it's very complex because you have veins at this level, and you can be tempted to coagulate veins. I saw sometimes some movies in meetings dedicated to technical issues, and I said, I don't understand how it was possible to have this postoperative MRI with these veins, and suddenly I saw the surgeon coagulating the vein and cut. Okay, I have understood. Never do that, never do that. Third, because no spasm, if you have a subparial dissection, in a sense, vessels are just protected by the pia mater. So that means that you don't need papaverine and to say, I hope that the patient will not have any stroke following surgery. Third, because it's not logical, and Yazergil himself nonetheless described some cases like this, to say you have an invasion of the operculum, you have an invasion of the sylvian, insula, because he was a surgeon much more dedicated to extra-arachnoid surgery. He splitted the sylvian fissure, probably better than me because I'm not so skilled, to remove the insula, and finally, after that, he removed the operculum by telling there is a tumor. Please just remove the operculum, because we are speaking about brain tumor, chronic brain disease. So remove the operculum, invaded by the by the tumor for oncological issues, and then you will have anatomical issues more or less solved with a very beautiful surgical access in agreement with the recent paper by Bennett and Mitchberger. Fourth, and probably because this is the most important, because the morbidity is reduced if you do a review of the literature with the big neurosurgeons splitting the Sylvian fissure. Definitely, I'm not able to do that with a so high level of reliability, 5 to 10% of severe permanent deficits. It's not my imagination, just facts in the literature. While if you do a trans-Sylvian approach, less than 5% of severe permanent deficit. And you will see my results, you know already, less than 1% of permanent deficit. So a factor 5 to 10 times less in speaking about a permanent deficit. So what do you prefer? Fifth, thank you, Emmanuel, because you can learn to do that much more easily directly into the lab, because to open a Sylvian fissure, of course, it's not the same when you are doing a surgery in real life in a patient into the operating theater, and especially with the risk of spasm, bleeding, and so on. But to learn to have a transopercular surgical approach is not so difficult, especially with very good specimens and the new methodology not apply to the intraoperative navigation, but applied to the extraoperative navigation when you are doing dissection. And then finally, you will see that at the end, the fascicles are always in the same location because the convergence constraint related to anatomy we spoke about this morning with Santiago. You can tell me, yes, but we know that Broca's area does not exist, blah, blah, but because there is a tumor, so you cannot remove the operculum when the operculum is not invaded by a tumor, and especially in the left dominant hemisphere within the pars triangularis or opercularis. No, you can. It does not mean that you can remove the left inferior frontal gyrus like this under general anesthesia in all patients with 100% of recovery. That means just that according to the awake mapping, you will adapt the surgical trajectory through the operculum according to the map of this patient at this moment, and sometimes to go through the pars triangularis. But finally, it's not so frequent. We had the same observation with Emmanuel. Most of the time, you can induce naming deficit, but through the pars opercularis, which induced, in my experience, in less than 10% of cases, the typical speech arrest, which is in fact located, speaking about the output, of course, within the ventral premotor cortex, Brodmann area 6, the lateral part of the precentral gyrus, so you can use the terminology you want. It's not in the pars opercularis. But once again, the limitation of neuroplasticity is the connectivity. So if you select, for instance, a transopercular parietal approach, I will speak about that at the end, sometimes for the zone 2 of Nader-Sané, because you have the same problem, of course, to have this access, especially if you want to split the Sylvian fissure posteriorly, it's a nightmare. So you can go through the supramarginal gyrus, especially in the left dominant hemisphere, and be careful about the lateral part of the superior longitudinal fascicle, SLF3, because if you cut it, the patient will have a complete and permanent anarthria, at least articulatory disorders. So once again, limitation is the connectivity. So now we'll speak about the right non-dominant hemisphere, because many of you probably did this kind of surgery through the operculum, because you know that finally you have a better view. But in the right non-dominant hemisphere, we don't care. It's under general anesthesia, because in front of the precentral area, I have no risk. For you, you have no risk. For the patient, you have this kind of risk. We have seen this morning. I mean, the executive function, the mentalizing, the double task, the multimodal processing, semantic processing, and so on and so on. So this is the reason why, yes, I changed radically my view when I met Guillaume Herbet, my neuropsychologist, who is not just a neuropsychologist. The question was raised this morning, neurologist, neuropsychologist, speech therapist, blah, blah. No, PhD in cognitive neuroscience. And then you increase the level of understanding. And then you can have a real online connection into the operating theater between specialists in cognitive neuroscience. And we should be when we operate the brain. And he demonstrated to me on the past 10 years patients still alive with insular surgery, especially in the right non-dominant hemisphere, by administrating a posteriori the mentalizing task that I have induced many deficits, at least in 15% of cases, by going through the right inferior frontal gyrus. And we published that in Cortex. I mean, my goal is not to do experimentation into the operating theater by adding task and task and task. But first of all, because I have this chance due to the long-term follow-up, and once again, many patients still alive, to say when we have new ideas, it's very easy. We can ask to the patient retrospectively to do neuropsychological examination after 5 to 10 years of follow-up. And what happened, I don't speak about those with anaplastic transformation. And what happened, I remember 5 or 6 years ago, Guillaume came to my office and he said, okay, you are a good neurosurgeon, you have good results, yes, but tell me the truth, your patients are not well. Okay, thank you very much. How is it possible to improve that? And then I asked him, is it possible to have a new task, additional task into the operating theater? And he told me yes. And it's exactly what we did. It's true also for the bimanual coordination. I remember that Hugues Duffau, very good neurosurgeon working in Istanbul and very involved in insular surgery, told me, in fact, I have a problem, just one. Yes, at the level of the corona radiator, when you have the junction with the internal capsule, because I'm afraid above the circular sulcus of the insula to cut the pyramidal pathways. And I said, you have just to stimulate under general anesthesia if you want. Probably you will speak about that, Lorenzo. I mean, you don't need to wake the patient. Yes, but you will see movies at the end. When you wake the patient and when you stimulate at this level, you will induce not involuntary movement because you are not stimulating the pyramidal pathways only, but also the network involved in the control of movement, and you will induce arrest of movement. Once again, it's not absolutely mandatory, but you have not to decide. You should explain that to the patient before surgery, and it will tell you you can cut more or not. Or I want absolutely to preserve a perfect bimanual coordination because I am an ophthalmologist, surgeon, for instance. It happened to me 1 year ago, and the colleague now is able to operate under microscope in this location. Once again, you have seen this slide this morning, but you see now, try to change your mental imagery and not to see a 3D representation of the FEF, the frontal eye field with the network underlying the fibers. And when you stimulate, you induce involuntary saccades related to attentional processing. But try to see how it's possible to use this knowledge in order also to remove more or less inferior frontal gyrus in the so-called right non-dominant hemisphere. Once you have removed the operculum, once you have removed, subpially speaking, the insula, because more or less we don't care, you have at this moment just a ball within the insula. The most important is to identify the pathways in the depth, because the question already asked, and this is, of course, the most important part of the surgery if you would like to induce, to avoid to induce permanent deficit, is where to stop in the depth. The answer is just an evidence, pathways, subcortical connectivity. So again, in the left hemisphere, when you stimulate posteriorly and upperly, you will induce phonemic paraphagia with a repetition disorder. So the SLF plus minus the arcuate fascicle, so conduction aphasia. And of course, the temporal stem, we have seen on the third slide, you remember the coronal dissection. In fact, now should be function. I mean, when you stimulate in the left so-called dominant hemisphere, you will induce semantic paraphagia at the level of the inferior frontal gyrus in the depth, at the level of the temporal, superior temporal sulcus gyrus if needed, because not just only insular tumor, but paralimbic tumor, at least as you will see in 80% of my experience. So the very bulky insular, pure insular tumor is not so frequent. Maybe I have a bias of recruitment. And, of course, at the level of the temporal stem. And why it's very important? Because you know that under the temporal stem, you have the lateral part of the anterior perforating substance with the lenticular straight arteries. So if you are already into the contact of the anterior perforating substance, and if you're afraid, of course, to have stroke, that means that, in fact, you already cut the ventral semantic pathway. And I can tell you that the patient will have a permanent deficit, at least according to the postoperative neuropsychological examination, in more than 80% cases. Okay, we have understood, but we spoke about the left hemisphere with semantic paraphagia. No, it's the same thing in the right non-dominant hemisphere, speaking about the non-verbal semantic communication, which is absolutely crucial for enjoying normal life, especially speaking about social cognition. And why it's important? Because since I have understood that, and finally it's not so, it's a little bit too recent to me, I also perform systematically awake surgery, not for the transopercular approach only, not just to remove the insula, finally, definitely it's a pile dissection, we don't care more or less, but to identify the IFOF in the right non-dominant hemisphere, because I am protected to the lateral part of the anterior perforating substance. And you will see my results in the past 10 years, 2 strokes related to damage of the lenticular striate arteries. The last 10 years, 0. Because, of course, I have no reason to damage the perforating arteries because I am protected by the temporal isthmus. And I know that, anatomically speaking, but in fact, into the OR, I know that thanks to functional mapping in the so-called right non-dominant hemisphere. And in addition to, you understand the discussion we had this morning, if the PPTT semantic association task, for instance, is negative, then you can implement the mentalizing task, and you will induce some modification of the behavior of the recognition of faces expressing emotion in front of you by stimulating the temporal stem. So that means that you will not induce this kind of subtle deficit, you know where to stop, and you will not have anymore any vascular disorders related to the lenticular striate arteries. So finally, it becomes just an evidence. It's very easy. If you want to go through the parietal operculum for the zone 2 in the right non-dominant hemisphere, please awake the patient in order to avoid to induce any permanent deficit regarding the spatial cognition by administrating, for instance, line bisection tasks. And then now, of course, you will finally be into the contact of the premodal pathways, but you know that at this level, you can also induce very frequently somatosensory disorders related to the fact that you have also the somatosensory thalamocortical feedback. So that means that if the patient is not awake, it will not tell you, oh, I felt something, sometimes more or less like pain at this level. And you know where to stop posteriorly in the depth. So definitely it's more or less an evidence. I will not speak too much about the claustrum because I was never able to see the claustrum by myself during surgery. When I started to see in all cases a gray matter, it was the lentiform nucleus, explaining why I know that I removed claustrum, especially thanks to the postoperative MRI, without so many cognitive disorders. So the question is, what is exactly the role of the claustrum? And there is a society actually in the world trying to answer this question due to Crick, who like to believe on the fact that it was the center of the soul. Okay. So finally, articulation disorders, we spoke about that. And sometimes you can do this very extensive resection. It's exactly what I did when I was younger because epileptic status, and the patient was improved. But of course, now you have imagined that patient is not hemiplegic, but I cut the right IFOF. I changed the personality of the patient. Many patients were depressed or modification of the behavior, not able to return to work due to social cognition disorders. And finally, I did not understand that in this period. So very quickly, the results now, until 2 years ago, approximately 200 patients with insular low-grade glioma, most of them with pharmacoresistant epilepsy. Definitely in my series, as I told you, more or less 80% of paralimbic low-grade glioma and not so frequently pure insular low-grade glioma. Initially, I did approximately 50 patients under general anesthesia, and I induced modification of the emotion, of the cognition, and so on, but I knew that only 10 years after. So now, of course, in all cases, I will do subpial dissection with no spasm and through a transopercular approach under awake mapping, even in the so-called right non-dominant hemisphere. We finally a recovery in patients, except in these 2 cases. I induced a deep stroke when I was younger and a median extent of resection, if you include everything, 83%, because you have also pure insular glioma, and more, as I've demonstrated this morning, very small tumor discovered incidentally. But when you have the typical left, right, eventually frontotemporal insular tumor, then I have the habit to leave, you know, that 85% of tumor, and I did exactly, I reproduced the same thing this week too in another patient. So with, because the volume was 40 cc before surgery, 6 cc, and the patient had no seizures anymore, but I did not remove completely, of course, the anterior perforating substance. Improvement of the epilepsy in more than 80% of cases, so you can really improve the quality of life too. I said this morning that you can remove the hippocampus if you want or not, but at least I have the habit to do that in intractable seizures, and suddenly I can change radically the natural story of the disease. And so I did total or subtotal resection in approximately 80% of cases. It's not related, finally, to the volume of the tumor, but the limitations. Anterior perforating substance, I decided in agreement with the philosophy I developed this morning to not deal anymore with the anterior perforating substance, and I have the habit to leave approximately 3 to 5 cc at this level. And the zone 2, but to try to better solve this problem, I decided sometimes, it's a talk about a transopercular approach, so you can see that I removed the temporal, superior temporal gyrus, the inferior frontal gyrus, but also the parietal operculum in a patient with real complete resection because still under surveillance with no recurrence, while she is a left-hander. I have the habit to reoperate more and more, as I said this morning, of course, but also within the insula. And finally, initially I was a little bit afraid about a vascular problem, and even after 3 to 4 sometimes surgery, because now I have to have this, never I have induced another deficit related to the fact that I reoperated that. Now, to be totally honest, it's 82% of patients still alive with so this follow-up, but we spoke about oncological issues this morning. And to conclude, so the question is to know how to make this link between the function and the structure, and definitely think that it's probably one of the main dangerous parts in the brain, because if you cut here, you will disconnect approximately 40% of the brain, of the hemisphere. And if we are not aware about that, you will say, oh, finally, just 7 millimeters more, and I will remove 1 cc more of the tumor. Don't do that. We thought about a new classification 10 years ago with Emmanuel, and finally, I think it was not a bad idea even today with the functional issues we spoke about. I mean, according to the migration of the tumor within the white matter tract in this specific location, because you have the crossing with the different pathways we have seen. So the conclusion is, once again, if you know the role of the insula, namely the possibility to compensate, and probably thanks to the intra-hemispheric connectivity increased, and or the contralateral hemisphere too, and if you preserve the white matter tract, but by knowing the real function and including in the so-called right non-dominant hemisphere, finally, the risk of permanent deficit, I will be a little bit hard with me, is 1.5 permanent deficit, while now today it's really a little bit lesser. So the take-home message, it was your question, I had to conclude at the end. Is it good to do a transopercular approach? The answer is we should do a transopercular approach in at least 95% of cases. We can discuss sometimes about a very small tumor by splitting the Sylvian fissure if you have no vessels. Of course, we should not be dogmatic, but in my experience, in more than 95% of cases, the answer is definitely yes. Thank you very much.